Hello, Dr. V and Dr. Miller. My name is Rasha Botros, and I am the nurse practitioner student at the ECPI University. My presentation today is about the hyperlipidemia or the hyperlipidemia management. Let me share my screen for the presentation. First of all, I'm gonna start with the pathophysiology. According to the American Heart Association's 2016, hyperlipidemia is a pathological disease that is used for a level of a total cholesterol concentrations in the blood of 240 milligram per dc or higher. This lipidemia term is related to the abnormal lipid values that associated with disease or increase the risk for a disease which necessitates a lipid-altering therapy. This lipidemia actually it consists of several components like total cholesterol, low density lipoprotein, triglyceride or lipoprotein levels. When these levels is above the 90th percentile or higher, this is abnormal, or the high density lipoprotein cholesterol or ApoA1 levels, if they are lower than the 10th percentiles for the general populations, we can call this as dyslipidemia. Pathophysiology, when there is abnormal high level of total cholesterol, the LDL will accumulate and build up deposits of plaques in the arteries, which associated with increased risk for coronary artery disease and stroke. Prevalence of hyperlipidemia. A recent analysis of the prevalence of hyperlipidemia documented that more than 100 million Americans have elevated level of low-density lipoproteins, which account for 53% of Americans adults who receive a medical treatment. Epidemiological research confirmed that almost 31 million Americans have high total cholesterol level that exceeds 240 milligram per deciliters, which double the risk to develop atherosclerotic cardiovascular disease, which is ASCVD, as compared to the people with normal level of total cholesterol. Hyperlipidemia is more prevalent among the non-Hispanic Blacks population. Risk factors of hyperlipidemia. We can see like there are modifiable risk factors which we can prevent or work on, like the diet that is high in trans fat or saturated fatty acids, smoking, increase the risk for hyperlipidemia, physical inactivity, and obesity. There are secondary causes of elevated LDL, several diseases such as type 2 diabetes mellitus, elevated blood pressure, biliary obstructions, hypothyroidism, and chronic kidney disease. Some medications such as glucocorticoids, diuretics, cyclosporin, and HIV medications that may increase the risk for hyperlipidemia by increasing the level of the LDL-C. Physical assessments. A comprehensive examinations may reveal some physical findings such as we can find or we can see elevated blood pressure, xanthomata. This is like a sign. It means this is a depositions of yellowish triglyceride particles that can appear in various locations in the body, but especially in the upper eyelid. The atherosclerotic fundoscopic changes related to cholesterol accumulations in the arteries, carotid broi, femoral broi, altered or diminished peripheral pulses. Also, in patients with elevated LDL level, we have to check or we have to evaluate the diet history should be reviewed in details, medication list and steroid should be reviewed, medical history of particular disease such as we mentioned before, type 2 diabetes that is poorly controlled, chronic kidney disease, inflammatory diseases, and obesity, TSH should be checked, physical activity questionnaires should be evaluated. Now let's talk about the diagnostic findings. For hyperlipidemia, the main way to diagnose hyperlipidemia is the blood test. Obtaining a blood test to determine the full lipoprotein levels profile but after 9 to 12 hours of fasting. According to the adult treatment panel, the ATP3 classifications of the LDL, total cholesterol, and HDL, we have certain numbers. We can determine which number is optimal, which number is below normal, which number is high or above normal. And we check usually the LDL, the total cholesterol, and the HDL. Clinical presentation. Research has proved the relationship between plasma cholesterol levels and atherosclerosis. Hyperlipidemia is a significant risk factor for coronary artery disease morbidity and mortality. More than 85 million American people have a clinical atherosclerosis that is mainly related to dyslipidemia. Clinical ASCVD, this including like a stable or unstable angina, acute coronary syndrome, history of myocardial infarction, stroke, transient ischemic attacks, or peripheral arterial disease. Now we're going to talk about the pharmacological treatment. There are several families of medication that can treat the hyperlipidemia. The first line, or the most important one, is the HMG-CoA reductase inhibitors, which are the statins. That includes lovastatins, pravastatins, simvastatins, fluvastatins, atorvastatins, and rosuvastatins. Fibrate or fibric acid derivatives, such as gemfibrozil, fenofibrate. Fibric acid derivatives, they are, we call it as PPAR alpha agonist, that has been shown that it works on the triglyceride. It reduces the triglyceride by 50%, and also it works on the HDL, and also reducing the LDL level and reducing the main coronary events. The third group is bile acid sequestrants, and such as the cholestyramine. Cholestyramine, which is the BAS or bile acid sequestrants, it actually works mainly on the binding the bile acids in the intestine, that in consequences will prevent the reabsorption of the bile acids and increasing the conversion of cholesterol to bile acid. This results in increase the clearance of the LDL and decrease the LDL level in the blood. Number 4 is niacin. Niacin also is a group that works mainly on the HDL, which means increasing the HDL and also lowering the very low density lipoproteins, which in turn will reducing the low density lipoprotein. The ezetimibe or Zatia, this is usually effective when we combine with the statin. Some vitamins or antioxidants or herbs natural product, such as the coenzyme CoQ10, also it has some evidence as good to take it with the statin. If the patient has liver disease, most of the antilipidemic drugs is contraindicated except the bile acid sequestrants, because it only works on the intestine. Non-pharmacologic measures. The non-pharmacologic measures is very, very important in management of hyperlipidemia. Exercise more than 150 minutes per week of moderate to high intensity exercise. Dietary therapy, reduced intake of saturated fats. It should be less than 7% of calories. Recommended of DASH diet and the Mediterranean diet. Consuming plant sterols 2 grams per day. Dietary cholesterol intake of less than 200 milligrams per day. Also increased monosaturated fat intake. We have to encourage weight loss, especially 5 to 10% of the body weight for people who are obese or overweight. Now I'm gonna talk about some papers, some recent research, and talk about the management for hyperlipidemia. Brenton Optimizing the management of hyperlipidemia. This is Brenton 2017. Basically, there are several medications that can prescribe to treat hyperlipidemia. Brenton actually determining the risk factors for the ASCVD is the main tool that should be used by healthcare providers to choose the right treatment. So in this paper, the researcher used the algorithm that is recommended by the National Lipid Association's patient-centered risk assessment. The major risk factors for the ASCVD are related to age, positive family history of coronary artery disease, cigarette smoking, hypertension, and low high-density lipoprotein. Another paper research is reviewed about the new treatment approach supported by research. The new approach it's for aggressive reducing the LDL levels that can be achieved by statin therapy, which is the first line of treatment for lowering the low-density lipoprotein. This approach is a step up from the ATP3 and all other major lipid guidelines researchers. These researchers, they actually stated the adherence to statin therapy that result in reductions of the LDL levels to less than 40 milligram are linearly related to lowering the ASCVD risk. The recent treatment recommendations is to be aggressive and to provide the maximum tolerated statin dose if needed before switching to non-statin therapy. The third article that was reviewed was done by the researcher Ehrlich, residual risk of statins. The researchers came up with surprising results of statin therapy. Several studies that documented the success of lipid-lowering medications, especially statin pharmacotherapy, in controlling the blood levels of the low-density lipoprotein. However, the corresponding reductions in coronary artery disease-related events has been less accomplished. Recent research articles discuss the fact that the decrease in the LDL levels by statins does not always translate into reduced mortality, a phenomenon called a residual risk of statins. And it is supported actually by 2 published articles about the residual risk of statins. The new medications, the Evolucumab. This new medications is actually a monoclonal antibody that inhibits the protein convertase. It's called PCSK9 and effectively lowering the LDL levels by approximately 60%. This kind of medications is an injection and taken subcutaneously, and it come with the 2 doses, 140 milligram. It's taken subcutaneous injections in a pre-filled syringe every 2 weeks, or a higher dose, 420 milligram subcutaneous once monthly. 2 articles that were recently published that discuss the positive influences of these medications, or the generic is Raptha, and the 2 articles supported the effective of these medications in lowering the low density lipoprotein. The 5th article that was reviewed about the Mediterranean diet. Giovanni 2013. Mediterranean diet is composed of consumptions of high amount of the monosaturated fatty acids by additions of olive oil to daily diet. Also, daily consumptions of fruits, vegetables, whole grains, cereals, and low-fat dairy. Weekly consumptions of fish, nuts, and legumes. Relatively low consumptions of red meats, and it suggested it should be twice a month. Giovanni 2013 reported the benefit of the Mediterranean diet. It has a protective effect on the component of the metabolic syndrome, such as the HDL, triglycerides, systolic and diastolic blood pressure, and also blood glucose level. Patient education. Most important thing, we have to encourage the patients or talk about the lifestyle modification. Exercise And some informations about the exercise: a minimum of 30 minutes of moderate intensity aerobic exercise such as brisk walking is recommended on 2 days each week, or alternative like 20 minutes of vigorous intensity aerobic exercise such as jogging on 3 days each week. These recommendations in addition to the routine light intensity activities of daily living. Exercise programs that can be used: aerobic exercise, resistance training, and stretching exercise. Some informations about diet: as we talked before, reduced intake of trans fat, increased intake of the monosaturated fat, increased consumptions of tree nuts and legumes, increased or introductions of plant sterol supplements to produce the most beneficial change in the lipid levels, and the Mediterranean diet. We talked about the weight loss, smoking cessations of the patient is smoking, moderate alcohol intake, and the adherence to the medications, socioeconomic considerations. We have to choose the reasonable prices for medications, and psychological considerations provide autonomy and involve the patients in decision making as a part of the medical management. And these are my references. All right. Thank you. Thank you.